Hi, my name's Kate Stern. I'm a fertility specialist. I work at the Royal Women's Hospital and I work also at Melbourne IVF. I'm very pleased to be here to be sharing some information with you today about fertility preservation for young patients with lymphoma. So I'm going to give a little presentation and then we can take some questions at the end. But thanks for asking me. So the sort of things that I want to talk with you about today include why is this discussion relevant? Why are we even talking about this? We're going to talk also about the risk of infertility with cancer treatment, how we can protect and preserve fertility, and then what to do later on after the treatment's over. We'll also just try and put it all in perspective and try and work out exactly what's important. And I've just got a few slides at the end to show you how you can seek information. It's awful when you feel you've got nowhere to go for information, but there is lots of information out there. First of all, I just want to run through a couple of definitions for you, just because I still get confused about these things, and I think most people do. So sorry if you already know this. Infertility means a difficulty getting pregnant, whereas sterility means an absolute inability to get pregnant. So sterility would be men that have no sperm or women that have no eggs, and that means impossibility of getting pregnant because they don't have their own eggs or sperm. However, they could still get pregnant other ways. Menopause is like a diagnosis that we make retrospectively for women or young girls who've stopped having periods for well over a year. And it's important that this is seen as you have to look at this differently to the term premature ovarian insufficiency. Now, that is a term that we use for young people or anyone whose periods have stopped. So it means that person may, in fact, be menopausal, but they may not. It may be that their periods are going to come back. So that's the technical term we use for young women when we're worried about their ovarian function. Premature ovarian insufficiency, or POI, you might see it written that way. Fragile ovarian function means there are still periods and we know there are still eggs, but the quality is very fragile and we're worried about patients developing premature ovarian insufficiency. And when we say eggs or oocytes, that just means the eggs, the gametes in a woman, and sperm or spermatozoa or spermatogonia, they're all reflecting the sperm for men. Spermatogonia, it's a big word, that one, I get stuck with that one all the time, means immature sperm. So, at the end, if there are any other words you want to talk about, I'm happy to go through them. So it's really important to understand that this is a very big issue because for young women and young men and kids, having cancer is not particularly unusual. So about 1 in 570 young women and about just under 1 in 500 young men or boys under the age of 35 will develop cancer. So it's not that uncommon. So there's lots of different ways of looking at statistics. So we can say 1 in 570 or 1 in 496, or we can say for every 100,000 people, 40 women will have cancer in a young age, or 54 boys. In Australia, we get approximately 1,500 to 1,600 cases of cancer in young people a year. That's why we're all so busy. So it's important to understand that cancer is not that uncommon, and that's why it's so important to have this conversation. And what's even more important is to understand that, fortunately, given most young people will recover and survive well after their cancer, we need to be talking about life after cancer, and one of the most important things is fertility. And it's interesting when you talk to cancer survivors, they really talk about the fertility as being so important, and if they haven't had it discussed with them, they feel frustrated or angry about that. And the other thing is that when your doctor talks to you about fertility, it's saying, okay, well, it's important because you're going to get through this, and so we want to talk about your fertility. So, it's important. It's an important thing. Now, in terms of causes of cancers in young people, lymphoma and leukemia they're the most common conditions in little kids. So under 14 years of age, for both girls and boys, leukemia is the most common cancer, followed by lymphoma. And when I say lymphoma, I mean Hodgkin's and non-Hodgkin's. Again, in young people aged 15 to 24, hematological malignancies are the most important for young girls. So lymphoma would be the commonest cancer in young women from the age of 15 to 24. And it's the second most common in young men. Testicular cancer is more common. As we get a bit older, breast cancer becomes the most important condition for young women. Lymphoma is less important in young women. We still see it, but it's not quite as common in that age group, 25 to 35, whereas for young men, lymphoma is still relatively common. So we know that cancer is not uncommon. We know that lymphoma and leukemia are two of the most common cancers that young people have. So what sort of effect do they have on fertility? I'm going to start off talking about girls because, they are more important anyway. So if we look at the patients that come and see us at our fertility centre, referred to talk about fertility, you'll see that lymphoma and leukemia are the most important factors, are the most common reasons for referral. So that sort of gets in your mind, well, there are going to be some fertility things with this. And in this big graph, which we call a pie graph, the orange, which with HL means Hodgkin's lymphoma, L is leukemia, and non-Hodgkin's lymphoma is in the pink. So you can see that's over 50% of the referrals for young people. And that is because the cancer treatment can affect fertility. So this is a very enormous study of over, I think, 16,000 young people, and it looks at fertility further down the track. And you can see here that not in the pink area, non-Hodgkin's lymphoma and lymphoma are associated with a lower pregnancy rate than the general population. The big line, the red and white, the red running line means the average population, the average pregnancy rate, and this shows you that patients that have lymphoma, it's lower. How can these cancers affect our fertility? Well, they can have effects in lots of different ways. They can affect the brain. The upper part of the brain, called the hypothalamus or the pituitary, can be affected by radiation or tumour, and this can have hormone effects, but also it can have psychosocial effects. The cancer can also cause damage to the ovary, and that's really what we're talking about today with girls, and that's why you can see the hazard sign. But also the radiation can cause damage to the uterus as well. So if you have pelvic irradiation, it can have some effect on the uterus. So the cancer drugs themselves affect the eggs. So that's the major impact on fertility. So the age of the patient, the type of drug, the dose of the drug, plus a few other sort of individual idiosyncratic things all affect how much damage is inflicted on the ovaries from the cancer drug. So if you look here, the two photos, the one on the left with the little white discs everywhere, so I don't think I've got maybe I can show you with a pointer. Here you can see these little white discs. They're the follicles, so they've got the eggs. So this is the ovary of a 20-year-old. We'd say that's pretty nice, really, looking at all those little eggs. This is the ovary of someone who's had serious chemotherapy. Otherwise, if I didn't know about this, I'd say, well, this looks like someone who's 40. There might be one or two follicles or eggs in there, but I really can't see many. And this is a result of serious high-level chemotherapy. So just to show you what happens. For most young people having chemotherapy, the ovarian function will stop with the chemotherapy, and that's due to the chemotherapy and sometimes also to the medicines that we're using to protect, which we'll talk about later. But for most young people, ovarian function will come back after. So there'll be this big insult, you can see here red from the chemotherapy, and then ovarian function will recover. But we'd never just go, oh yeah, that's fine, it's going to be fine, because it's not, because it's still compromised for the future. So the ovarian function coming back is reassuring, but only temporarily reassuring. So I've tried to show in this sort of slightly daggy cartoon that I've done, I'm not very good at PowerPoint, you've got the red, which is the damage from the chemotherapy, and usually you get some apparent recovery, and I've called that temporary ovarian failure with apparent recovery. But then further down the track, the ovaries will stop working. However, for some patients who have very high dose chemo and radiation, say with transplant, there will not be any recovery. And we'll talk about percentage chances of that in a minute. But I want you to remember this, that the chemotherapy could have permanent effects or it could have temporary effect, but it will have permanent sequelae. So a young woman would have ovarian shutdown with the chemotherapy, ovarian function comes back, and then maybe 5 or 8 years later it goes away again. So this is a bit of a back of the envelope statistics. Really, it's very complicated getting these statistics. But this is just to show you that if you have Hodgkin's disease and all you have is the basic treatment, which is called ABVD, you know, oncologists, they always talk in initials. The chance of developing ovarian failure at that point, not in the future, but at that point is less than 5%. So that means that 95% of young people who have ABVD, young girls for their chemotherapy for their Hodgkin's, their ovarian function will come back. It will be affected later on though. So what happens is the total number of eggs is reduced, so they'll be fine for a while, but then there'll be a reduced pool of eggs later on. But there's only a 5% chance at the time of the ovaries being wiped out completely. Very important to understand that, even though it is going to have effects later on. If you go on to higher level treatment, and I'm not an oncologist, but like a regimen that's commonly used is called BEACOP, BEACOPP. That can have more of an effect on the ovaries, stopping ovarian function for good. But again, probably more than often than not, ovarian function will come back, but it will definitely be fragile later down the track. Non-Hodgkin's disease, it depends what regimen, but if it's a RCHOP or something like that, then there's about a 10 to 40% chance. If a patient has leukemia, amazingly, considering the drugs go on and on and on and on for about 2 years, the ovarian function is actually pretty well preserved for some time. If a patient's having high-dose chemotherapy and stem cell transplant or bone marrow transplant, the risk is high. But it's interesting, you know, because we used to say the risk was like 90 to 100% of the ovaries not working. Now we say about 70%. So there is no doubt that it's more likely that the ovaries won't work, but it's not 100%. So let's talk a little bit now about strategies to preserve fertility for young patients. So I just wanted to show you this slide to show you the difference, show you the difference between mature eggs, which are taken in egg freezing, and little eggs in tissue freezing. So two of the commonest options for fertility preservation in young women are egg freezing and ovarian tissue freezing. So this is a slice through of the ovary, and you can see these follicles. These are big eggs, and then around the big eggs are hundreds of thousands of tiny little eggs. So at any one time there'll be a few bigger eggs, and then when we do stimulation we get more, but most of the eggs are tiny little eggs. So potentially when you take the tissue, you've got a huge supply of eggs. The third thing we're going to talk about is ovarian protection with an injection called Zoladex. So first of all, ovarian tissue preservation. So this is a procedure where we take some ovarian tissue, part or a whole ovary, and we take it away and we slice it up and we freeze it. Hopefully we never need to use it because the patient's fine, but if we do, we put the tissue back in slices. Now, this is the only option for young girls and young women young girls who have not yet had their periods commence. Okay, so it's the only option. It's used also when there's a very high risk of permanent damage, say prior to transplant, given that we're going to have lots and lots and lots of those little immature eggs. We use it when we haven't got enough time to do a stimulation, or if we're worried about a patient during the stimulation. And we also sometimes do it in association with egg freezing. So here we have the uterus here, and this is a beautiful right ovary being beautifully displayed there. And so what we do is we take part of that ovary. And so this is what we do. We take part of the ovary, and then we'll sometimes extract any big eggs that we find, and then we freeze the tissue. Now these look quite big on the screen, but they're actually tiny little slices of ovarian tissue, about 1 by 3 by 10 millimeters, so really, really tiny. So they've got follicles in them. So then, if we want to, if we need to, we can graft the tissue back. So this is just to show you some ovarian tissue that's been grafted back into the side wall of the pelvis. Helpfully we've labelled there so we know. This is the ovary. We put some slices back there, And here we put some slices back in the anterior abdominal wall. So that's just under all the skin and the muscle in the abdominal wall. So just to show you that it really does work, this is a slide showing the anterior abdominal wall, and that sort of balloony thing there, that it's got an arrow, is actually 2 follicles. So that's 2 follicles in the tummy wall that have developed from that ovarian tissue. It is pretty amazing. And here, just to prove the point, here is an ultrasound showing the 2 follicles from that tissue that's put under the excuse me, under the ovarian, under the anterior abdominal wall. And then what we do is we do IVF. So we give a bit of stimulation and we take the eggs with a needle from those follicles. And this is what we can achieve. It's very hard work. It takes forever. It's not very easy. But this is twins born from taking 2 eggs from the anterior abdominal wall from that previous slide. So that was pretty exciting. That was the first time we were able to show that. These beautiful twins, beautiful, beautiful. Now, for young girls who have their tissue taken, because this has only been around for a few years, there aren't lots of cases to say, oh yeah, we've done hundreds of 9-year-olds. We haven't. But this is the slide which is actually taken from a newspaper, which talks about ovarian tissue which was taken from this girl when she was 9 and then put back, and she's got a beautiful baby. So we know that it works even when it's taken from very young girls, and there's no reason to think that it wouldn't anyway. So when we talk about young girls, this is just in our own unit with the Royal Women's and the Royal Children's Hospital in Melbourne. We've taken 43 ovaries or parts of ovary from girls with cancer and another 10 for other serious conditions, and 21 of those patients have been less than 10. So I think around the world there is genuine and general acceptance that this is important fertility preservation. So we are always worried about putting the ovarian tissue back when there's a risk of cancer cells, particularly with leukemia rather than the lymphoma, but we can never be complacent. So there are lots of different strategies that we employ to try and check the tissue. I won't bore you with them because they get a bit scientific, but if you're interested, you can read them on this slide. But just so that you know that we always have to be very careful about putting the tissue back. So we've talked about ovarian tissue, and now I want to talk about egg freezing, which is stimulation to get a few mature eggs. I just put this slide in just to show you a beautiful egg. That's not really got any importance here, but just this is a beautiful egg with its cells around it. So gorgeous. So with ovarian stimulation and egg freezing, it takes 10 to 14 days of hormone stimulation, and on average we might get 10 to 20 eggs. It's a relatively simple procedure to remove the eggs. It's just 10 minutes of sedating anaesthetic. So we might get 10 eggs and we go, great, fantastic. But for every 10 eggs, ultimately down the track, you're only going to make maybe 1 to 4 or 3 or 4 embryos. And that's regardless of whether you're young, whether you've had cancer, or you're just having you're making embryos with IVF. It doesn't matter whether it's egg freezing or IVF. You still have this loss rate between eggs and embryos. So the importance of that is that you can do a cycle, get lots of eggs, but then when you need them, you're not going to have that many opportunities. You might only get 2 or 3 or 4 embryos. It's just important for everyone to understand that. Having said that, there are lots and lots and lots of babies born now after egg freezing. We estimate to our patients that it's about 15 to 20 eggs will give you at least a 50% chance of having a baby if you're over 25, and hopefully a higher chance if you're under 25. So again, egg freezing in young girls. This is not data from us. We've probably done stimulation in about 5 or 6 young girls now under the age of 16. But this is taken from another group in New York, just showing that you can get eggs even when you're taken from very young girls. But you do need to be post-menarche or have had first period. So how do the options compare? Not that we're always choosing one or the other. Sometimes we're choosing both. Sometimes we're choosing neither. But on average, with egg freezing, you might get, say, 14 or 15 eggs. With ovarian tissue, you'll get hundreds and hundreds of slices, so potentially a huge supply of eggs. But with the tissue, it doesn't require having to have the stimulation. Potentially, you've got a big supply of eggs, but it's hard work getting the embryos. And it's not experimental anymore, but it is hard work when you put the tissue back to get good quality embryos. There have been over 140 births now with this, so it's well recognised. The egg freezing will take 10 to 14 days. You might get 3 eggs, you might get 10, you might get 20 eggs. But that's pretty sort of routine treatment now. We know we can get good embryos from the eggs. So, for some girls it might be worthwhile doing both, for some just one. So the third thing I want to talk about is how to protect the ovaries during the chemotherapy. What can we do to try and sort of make the eggs more resilient and, robust during that time of the chemo? So there is an injection called Zoladex, which is what we call a GnRH analog. And what that is that's a hormone that stops the production of hormones from the upper part of the brain to the lower part of the brain. So it stops the production of hormones from the pituitary going down to the ovaries. Now, it's complicated about how it works, but what it does is it tends to stop the number of eggs that are being ovulated or even sort of exposed to chemotherapy every month. And it has been proven in lots of studies in breast cancer, and there's enough evidence now that it's been registered in Australia as protection for all cancers, which is pretty good. So what we think it does is it just reduces the number of eggs that are damaged in the long term. So hopefully it means that if you were going to have your menopause at 35, maybe you'll have it at 40 instead of 35, but you still won't get on till 50 or what you would have normally. So just a little bit about male infertility and options, and I just love this slide. I showed this slide for months before I realised what the sacks of love were in the t-shirts. It's a bit embarrassing, but beautiful photo, I love it. So the chemotherapy or radiation can have an effect on the testes. It can also have an effect on the brain, etc. with boys. But on the testes, there's 2 types of cells. There's cells that make sperm, and then there's cells that make hormones. And the chemotherapy and radiotherapy can have effect on both sorts, but predominantly have effects on the actual production of sperm. So if we sort of think back to our slide about the ovary, here's a slide of a testis, and it might not look that much to you, but all those dark things are the start of sperm. So heaps and heaps of sperm in that tubule. Whereas here, you've got the supporting cells, but you just haven't got the sperm. So, it's a pretty similar thing. So in terms of what young boys and can do, we know that if you're post-pubertal and you're able to do a masturbated sample, that's fine. Sometimes if you're not able to for lots of reasons, but you've got mature sperm, you could have a testicular biopsy, and we get the sperm and we freeze the sperm. But if in young kids who only make immature sperm, it's actually hard work, like with the girls actually maturing the sperm from immature to mature. So we are taking testicular tissue from young boys, even very young boys, but we say this is still considered experimental. It's like where we were with the ovaries 20 years ago, and now we're pretty happy with it, but it really is still considered experimental. It's considered an important part of treatment, but we wouldn't be very sort of cavalier about the success at this point. So that reminds me, for young patients, we really need to be practicing our fertility preservation as we do with our cancer treatment, with very sort of strong ethical frameworks, particularly with experimental things like freezing of the testicular tissue. And we need to be guided by the best evidence and have consent from families. And the key is education. Really, the big key is education. So part of being able to educate our patients and their families, and to be quite honest, our health professionals better, we need to have good data. And so my colleague Antoinette Anazadu, who's an oncologist in New South Wales, has done an enormous amount of work to set up an oncofertility registry called the Future Fertility Registry. And so we ask all patients who are registering for cancer treatment to go onto this registry so that we'll be able to get national data, which will help us to know, okay, what works, what doesn't, what do we need to apply for funding for. Really important. I encourage everyone to ask their oncologist about getting onto the registry, please. The other thing is getting better accessibility to guidelines, national and international guidelines, and we're just redoing the Australian guidelines at the moment. There are now, I think Antoinette told me yesterday, over 30 international guidelines, and Antoinette and I have both been involved in some European guidelines as well. So we're trying to just update the national guidelines, but the importance of that is that information is there for patients and their families, as well as health professionals. So, decision making, it's all very well to know about all this, but on an individual basis, what do you do? And it's really important to understand what's right for one family and one kid is not right for someone else. So we really highlight the importance of individualisation of decision making. You've got to weigh up the benefits versus the risk for that person, and everyone will come to their own sort of comfort level of that. And it's really important because it's quite hard to do with all this rush time, but it's okay, we've always got time to sort it. So, as I said, it's important to find out as much as you can, to be as well informed as you can. And I'm going to leave a list at the end of this talk with websites. Now, the last thing I want to talk about is the cancer treatment's finished, you're starting to recover, come out of the fog. Wow, they said I'd be all right, and I am. First of all, that's often when you can fall in a bit of a slump because you're better, your body's just been in sort of survival mode until this point, and now you deal with it. That's okay, we're all there to help in that time. But the other thing is you might think, oh, okay, I'm okay now. Now I'm going to think more seriously, or even I've got time now for the first time to have the opportunity for fertility preservation. So we it's a conversation that we just keep having. Also, you might just want to link in with the service so that you can assess your fertility or your reproductive health. So that's a really important time. And we're always saying to our patients, look, as soon as you're ready, don't delay, don't care about a mortgage or this or that. Just as soon as you're ready, hop to it because you never know what's going to happen. So we're lucky in Australia. We've got really well-developed programs for fertility preservation. We can provide the full range of services, and we sort of take it for granted, but it's not like that everywhere else. We are working on improving our data collection. We're working on innovation, scientific and also clinically relevant innovations, and to get better practice guidelines. And we have quite good relationships with other countries about this, but we can always do better. So I just want to thank you for listening. I hope it's been helpful, and you can go back and look at some of the slides if you want to. There's a whole team, or a village, as some people would say, that are involved in this program. This is just our Victorian team. We also have help from New South Wales with our colleagues, including Antoinette and Azadu. We also get assistance for running our programs from industry, and we have some advisors from overseas who have been really, really helpful and encouraging. We're really lucky in Australia that we can offer fertility preservation to cancer patients at really no or minimal cost, at least in the short term. There is government support for fertility preservation, and at our big public hospitals, I can only speak for the Royal Women's, we're really lucky that we can offer care. So we don't think that anyone should not have fertility preservation because they can't afford it. Patients will often ask us, when should I start my family? And I say, well, you've really got to go back and talk to your oncologist. Number one, your oncologist has to be happy that you're fine and things are good. Then we think, well, as soon as everyone's happy that things are fine and physically your health is good and psychologically you've recovered and you're in a position where you can, we should just get on with it. There's no hard and fast rule, just as early as possible. Now, I didn't mention, but maybe this is a good time to mention, there'll be some patients for whom fertility preservation wasn't possible or for whom it was not successful. And it's important to know that there are other options available, including egg donation, embryo donation, surrogacy. There are always options. So in terms of having a baby, we would never, ever want to say there's absolutely nothing we can offer you if that's what you want. Zoladex is a terrific medication to try and protect the ovaries from chemotherapy effects, but it can make you feel a little bit crappy and unwell. It's like inducing a menopause, but very clearly we have to say it's a temporary menopause. The treatment with Zoladex never causes ovarian failure, but what it does is it temporarily suppresses your hormones. So you might get hot flushes at night, they call it the leg in, leg out, the sheets, dry vagina, feeling grumpy, some waterworks problems. These are common symptoms associated with the Zoladex, and they are always reversible when the Zoladex stops. So if there are persistent symptoms afterwards, they're related to the ovaries not working, not the Zoladex. So we like to see our patients after they finish the chemotherapy just to see how everything's going. We like to see them sort of 4 to 6 months later. Often patients will get referred to a formal clinic, a late effects clinic, or the menopausal symptoms after cancer clinic, and they will normally start there 1 or 2 years after they finish their chemotherapy. As I said, we like to see our patients 4 to 6 months afterwards, and then we would probably do some sort of assessment about a year down the track. It depends what the treatment has been. Important, though, to be very clear that let's say we do the testing at a year and the ovarian function or the sperm function is fragile. That doesn't mean it'll still be fragile in another year. You can have normal function coming back even after 1, 2, 3, 5, or even more years. So we'd normally like to sort of do some sort of hormone check-in about a year later. So for boys and young men, if they're post-pubertal, we would recommend checking the semen 1 to 2 years after they finish their treatment. So thanks so much for listening. I hope you found it helpful, and I've just got a list of the services.